My name is Joe Jemsek, and I'm part of the Physicians Training Program for ILADS, an organization to which I've belonged, had the pleasure to be involved with for several years. And during the time that I've been with them, early on I got involved with teaching physicians on site, and I think it's been a very good thing for the program, and certainly something that we should continue to seek to do and try to improve upon, try to expand upon. We treat exclusively patients with Lyme disease, or Lyme borreliosis complex as I call it, or perhaps borreliosis complex. These are generally very complex, very ill people who've been on a doctor trail, seen lots of docs, spent lots of money, very frustrated, very sick, disengaged, marginalized in a lot of cases. And it's a challenge, and I love it. The good news is we get a big chunk of people better, and we look at that as our building block, and it's like the base is kind of big and it shifts a little bit, but it's most of the shifting is done up here right now. Yeah. So it's not like we're starting over with each new challenge, each new patient. We've been at this long enough. We definitely see patterns. We've got hundreds of patients who've responded to, different programs, not necessarily just antimicrobials, but neurotropics or neuroleptics, psychotropics. Sleep management, nutritional management, all of that, and just understanding that the patient has to have their basic health needs met, their essential life functions, if you will. And I think one of the things that we do that break it down very simply for anyone that cares to listen is we look at it at 3 stages. First stage is preparation. That's understanding the patient, gathering the data, building on everything they have had done before, and not discarding it, but trying to integrate it into what's happening here, because there's a lot of studies going on. A lot of times things haven't been very successful, but there's still a lot of data. So we don't take a naive patient, and necessarily we see patients that have been around the block on the doctor trail. We use that data, and we can rule in or rule out other things along the way, and that helps immensely. Then we continue and get our patients prepared so that the fundamental aspects of sleep and sleep restoration, the fundamental aspects of control of pain are met without making the patient feel dopey. The patient is stabilized from a psychiatric point of view. If they're working with a good psychiatrist, we're more than happy. We encourage collaboration there. The next part of the program is a treatment phase, which will vary, but in which we have certain roadmaps that we follow. And there's a very good reason for why we go in a logical sequence. And then when that's done, and I think the big frontier in the future is brain rehabilitation. How do you get that brain better? That's the third part, because now you've excoriated or you've expunged the infections. Now you have a brain and central nervous system, peripheral nervous system, other tissues that can finally heal. How do you get that patient to heal? What sort of supplements do you give? What sort of ancillary services do you provide, such as hyperbaric? How important is brain training, brain exercise? Of course it's important, but what's the best combination? What's the most efficient way? That's going to be the next big frontier, I think, because the first 2 parts we feel like we have under fairly good control. Now that's not to say we don't have a lot to learn, especially in the area of biofilm, and we do have a lot to learn, of course. But many of our patients, if not the vast majority, if we can spend the time with them, and there's a lot of time, we'll get better. Then the question is, how do you keep them better? What criteria have you used to say they're better? And how do you keep them from relapsing? So what we're trying to do is build such a strong immune control of such a diminished infection load that it's virtually impossible for them to get sick again with this disease. We have to teach thousands of physicians how to deal with borreliosis complex. We just do. It's going to be a total departure from the compartmentalization that we have in medicine today, which is, isolate these specialties. One talks to the other, but they don't talk very well. They don't understand each other. And the poor patient with a complex problem never gets solved because there's not that capacity. So we have to go back to the roots of medicine, which is to know the whole patient, to listen to the patient, for Christ's sake, listen to the patient, and become good at a lot of things. Not everybody can do that, but you have to try. You have to be good at a lot of stuff. You have to be good at stuff that you weren't necessarily trained in primarily. And you can do it if you go to work and learn every day from your patient. My experience has been that when a person is motivated, comes and they have so many questions, and they sit down with us and they go through the day with us, and they're just blown away. They're just blown away. And it's so much fun to teach them or instruct them and learn from them. Actually, everybody has something to teach you, of course, but they're just blown away. Their jaws drop and they say, "Oh man, I never realized the complexity and some of the ingenuity that goes on here, and some of the science that's used, and the breadth of medicine that's required to do a good job with these complex patients in all disciplines of medicine, or almost all disciplines of medicine." Oh yeah, I think in future, I think we're going to have limologists. I think let's say something silly like limology. I mean, we're going to have 50,000 Lyme doctors in maybe 1.5, 2 generations. Complex set of infections, because it's going to turn the whole concept of chronic illness on its ear, virtually 180 degrees. Instead of and by the way, this takes away the whole issue of environmental toxicity, about which I'm not an expert, but obviously that plays a role, and I can't really speak to that. But I can speak to the whole set of infections that we see in our patients, suppressing the immune system, facilitating the expression of other diseases, of which there are quite a few, and pretty much, in the worst cases, robbing them of their ability to interact with their environment, making them a shell of what they were. Whereas in modern medicine today, where we have too much chronic illness to start with, I think every other person's got a chronic illness in our country. What's been in vogue since they invented steroids, which is only 40 or 50 years ago, by the way, is that, we all have autoimmune diseases, and we need to suppress that immune system, and we need to inject it with this and that and the other. I'll agree that there is an autoimmune component to Borreliosis complex, but I think it's transient. I've seen it in patients who've been firmly diagnosed with SLE, autoimmune hepatitis, rheumatoid arthritis, where those markers will melt away with treatment, with support, other forms of support. Not every single time, but they melt away, and it makes a big impression. And that person is very happy to be off steroids at that point. So right now we have a patch and pay system where we just, shut up the immune system, manage the patient in a chronic way with these very expensive immune modulators, if you will, in that circumstance. And the patient never really has a chance to fully recover. Their immune system is never going to recover as long as they're getting slammed with these things. What we want to do is we want to put that immune system back in charge to the extent possible, because it's been beat up, battered, disorganized, dysfunctional for a very long time, making very bad decisions about things that come into the body. And we want to organize that immune system, strengthen it, and get it to focus so that it has control over a set of pathogens that cause disease in the first place, and which was we haven't evolved to the point where we can control these diseases, by the way. I mean, so we're not back in the the survival of the strongest or fittest anymore, where the people that get sick just die off, and we genetically weed out those who are more inclined to become chronically ill. We don't do that. So I can tell you, we haven't evolved to the point to control these illnesses. These are crafty sets of organisms, and we haven't evolved. They attack us where it hurts the most. They attack us in our nervous system. The inspiration of doing this comes from patients who recover, but also from the knowledge that one gains once you are able to put links together and solve problems, and you see patterns. And once these patterns tend to repeat themselves, it's really pretty amazing and pretty inspiring. It makes you want to do more. It makes you want to be better. And so I think that my colleagues and I here at the clinic, we try to learn something every day or every week, and I think we do. And we do it by corresponding with each other, listening to the patients in particular, and making these links, and trying to involve as many other colleagues as we can, people that are smart and have their own ideas about things, that we're open to just about anything, but we still stay in a rather constrained clinical area, if you will. In other words, we don't just take a dance with the next pretty girl, if you will, or whatever the parody would be. We we gradually try new things. We try things one at a time, generally. If we're not doing well, we try to strip things back and say, okay, where we go wrong. And when we get somebody better, we say, what did we do right? What worked there? And then we try to think about other ways that that has happened in the past. So when someone's well, okay, what did we do? What was right? What was good? And it's very, very challenging. It's very inspiring, though, when you get it right.